Friends, I am back again with another important sensory modality. This is one of those sensations for which the patient comes to the doctor with this symptom. This is nothing but pain. I will be discussing this thing in three parts. And I will be dealing today the first part of the discussion. On the right hand side, man with the fire, that is what the Deshpande in 1644 described the pain pathways. It is there in the French Museum, and I have taken it from Meljac Wall's publication in Science. A is a fire, B is the point where these fire particles take up, and from these fire particles, along with the line they have created there, which is going through the vertebral column to the vein. So this is CC, is a thread or a tube-like structure by which the pain particles which are received will reach. Somewhere here D and E, you can just see there, they are valves which try to allow or disallow the pain particles, and then F is the point where the it is processed, and then there will be a response. That is what Deshpande described. Now we have changed a lot since then, and we will deal, or we will try to understand the pathways, the receptors, and the definition. Today, as I described, I will be dealing the physiology of pain in three different headings and three different lecture series. Today's lecture, I will give the definition, receptors, and pathway. In the next lecture, I will be talking about the processing of pain and the physiological basis at various levels. And in the next lecture, I will be talking about the physiological basis for the management of pain. Sir Charles Sherrington, in the beginning of the 19th century, coined the word nociception. Then he defined the pain as a psychical agent of an imperative protective reflex. This definition has certain issues which are debated. It is psychical, means the requirement of a conscious state of mind. For that reason, in 1977, the International Association for the Study of Pain, they sat together, they came to a consensus, and they defined the pain as an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or injury. This definition by far was accepted for 2 decades. Now, very recently, there were certain issues for the word unpleasant. Unpleasant may not be painful. For that reason, the people or the IASP once again sat and they changed that unpleasant to distressing. Now, the current definition says as pain is a distressing sensory and emotional experience associated with actual or potential tissue damage or injury. As a physiologist, we would like to see the pathway of pain. To begin with, what are the receptors for the pain sensation? This sensation is also known as a noxious sensation or nociception. The receptors are the free nerve endings situated in a different tissue planes. Here I am showing the skin, and you can see those 5 free nerve endings, the branchings from 2 different group of nerve fibers. One from C fiber, free nerve endings. These are slow conducting fibers, and you see that these are unmyelinated, and another from A delta fibers. The A beta fibers from the Pacinian corpuscles are just shown for the reference purpose. So that means there are free nerve endings for the pain. That means there are 2 type of pathways. One is the fast and one is slow. What are the stimuli for painful or pain sensation? Usually there is a specific modality of a stimulus has been attributed, but for the pain there is no specific modality of a stimulus. These stimuli include one mechanical, that is cutting, tearing, crushing, pricking, stretching. All the mechanical things, they will be one of the stimuli or one of the stimulus for producing the pain. Then comes the chemicals. The chemicals released out of the cell injury or inflammation. These chemicals include histamine, prostaglandins, 5-hydroxytryptamine, bradykinin, protons, that is ions, the potassium ions, ATP, adenosine, cytokines, number of cytokines, the calcitonin gene regulating peptide CGRP, substance P. All these cell injury products, some lipids or lipid molecules and inflammatory mediators and other chemicals participate, and they act as a stimuli. Pain can also be stimulated or triggered by the heat or by the cold, the noxious heat or noxious cold, that is thermal sensation. Leaving aside the high intensity stimulation of all the sensory modalities or any sensory modalities will produce pain. If one beats and produces sound, or you are sitting near the amplifiers and 120 decibel DJ is going on, and you will hear the painful sensation if it is crossing 120 decibels or above, or very severe light, that will also produce pain, or any pressure on even the pressure receptors will produce pain. So like that, high intensity stimulation of any sensory modality will produce pain. But that is non-specific. Thus, pain is mediated by a polymodal stimulus or stimuli, and here I am showing the pain receptors, that is the free nerve endings on the receptors. On the top we have the heat sensitive, the noxious heat or the painful heat sensitive. You have the TRPV1 and non-TRPV1 heat sensitive channels. Those non-TRPV1 heat sensitive channels are sodium channel or other channels. Then we have the cold. Severe cold also produces pain. For that we have the TRPM8. TRPV1 is a vanilloid transient receptor potential, vanilloid 1. Here transient receptor potential menthol 8 is a form. So that is one major stimulus for producing the feeling the cold, and that would produce the pain. There are other pain producing transient receptor potentials. They are known as a TRPA1, encarin. Encarin is a molecule present in the mustard, cinnamon or the garlic. So that would produce the pain which is produced by the cold. In the lower this thing we have one peptidergic terminal and the non-peptidergic terminal. The peptidergic terminal have number of potassium channels, sodium channels. Okay, that is different, but they are mainly consist of substance P, the calcitonin gene regulating peptide, neurokinins and bradykinin. The non-peptidergic terminal will have this potassium, hydrogen ions, prostaglandins, lipid molecules, ATP, etc. or may result from mechanical transduction in both the cases, the peptidergic or non-peptidergic. Here I am trying to show you the thermal nociceptive receptor behavior. You can just see the red filled line that would be activated above 42 degrees Celsius, and this is by the transient receptor potential V1 heat sensitive molecule, and as temperature increases, this channel is activated and that opens up and produces the exit potentials. Somewhere around 50 degrees Celsius, TRPV2 is getting activated and that would produce a further increase in the sensation, that the burning hot sensation. So that means you have a warm, hot and burning hot sensation. That means that is very painful. On the other side, in the cold, somewhere around 15 degrees Celsius, you start feeling a discomfort, and here the main molecule or the main channel is a TRPM8, transient receptor potential menthol 8, and this one will be increasing as dotted blue lines you can see there. 50, as the temperature is decreasing, the number of discharges are increasing. Somewhere around lesser temperature, another molecule, another ion channel or another molecule, another ion channel, that is a TRPA1, is getting activated. That would produce a severe pain. That is its limit begins with 17 degrees Celsius and below. So that will produce the pain. In addition, there are a number of other channels, sodium channels, the potassium channels, and they also participate in the heat sensitive pain associated with the warmth or the cold. Here is the inflammatory chemicals or the chemicals released after an injury. You can just see the cell products. The cell products include the potassium, the hydrogen ion, and the prostaglandin, serotonin, bradykinin. They are all released, and that will activate the mast cells. The mast cells release histamine, and then from the nerve terminals you have the CGRP and substance P are released, and that would further activate the blood vessels, and they will also release certain chemicals from the platelets. They will activate the platelets and release chemicals. So that means you have what are these cell injury products, the inflammatory products, all these things put together called the inflammatory soup. They will increase or send the impulses through the dorsal root ganglia and reach the dorsal horn. In addition, when the inflammatory mediators are there, they will increase the temperature of the area. So that would further sensitize the nerve fibers, because the nerve fibers become more sensitive because of the thermal, and the thermal things are also getting activated. That also to be considered. Now we look into the nociceptor signaling. The nociceptor signaling, the molecules are G protein coupled receptors. The signaling takes place. You have a number of chemicals there: IL-1 beta, NGF, leukemia inhibiting factor, IL-6, TNF alpha, histamine, bradykinin, PGE2, adenosine, H ions, ATP, platelet, and other molecules like substance P and CGRP. You have those macrophages, the mast cells, tissue damage, tissue cells, and platelets. All these things add up these molecules into the interstitium or around the free nerve endings. Now these free nerve endings have a number of receptors on their cell surface, and these receptors belong to one G protein coupled receptors that will bring about the action. There will be transient receptor potentials, either V1 or M or A or whatever. Then acid sensitive ion channels or purine receptors, P2X or ASIC on the other side. Then you have this side 2-port potassium channels, K2P, and we have the receptors for tyrosine kinase activation. That means tyrosine kinase receptors. So all these receptors are activated. So once they are activated, they will influence the ion channels and they will produce the receptor potentials followed by the exit potentials. These nociceptors are carried by two sets of fibers, as I have shown in my first graph. Just we will see them. The fiber group free nerve endings or the nociceptors for both. In terms of the sensory fiber classification, they belong to group 3 fibers, that is A delta fibers if you are looking at the Erlanger and Gasser classification. These are myelinated fibers. Conduction velocities range between 5 to 30 meters per sec. Diameter is around 1 to 6 micrometers. And this will carry the information of a sharp pain, acute pain. that would mediate all the reflexes and other things. Then another group of nerve fibers, the free nerve endings on group 4 fibers. These are unmyelinated C fibers. The conduction velocity 0.5 to 2 meters per sec, and their diameter size is around 1 micrometers plus minus. They carry the dull aching pain. On the other hand, the cold is by the A delta fibers, warm or the thermal heat by the C fibers. What are the differences in fast and slow pain? Fast pain is also known as epicritic pain. It is sharp, pricking, or acute, or electrifying. I have already mentioned these are free nerve endings carried by A delta fibers. They can be stimulated by the mechanical and thermal stimulation. They relate to the spinal lamina 1 and 5, and they form, after relaying, they form the neospinothalamic tract. That means the evolutionary wise, this is the new tract. It carries the epicritic or the discriminative pain. Because it is discriminatory, localization of the pain origin and the attributes can be definable with this type of pain modality. Whereas if we look into the slow pain, it is called protopathic pain. The protopathic pain, that's a diffuse, vague, burning, aching, throbbing, nauseous, chronic pain. So this very vague pain, you don't know, you cannot identify where the pain is, and if a doctor asks whether whatever organs he touches, he says that whether it happens here, whether it happens here, and he will say, but it's dull aching and dull aching pain. Receptors are again the nociceptors, C fibers of the fibers carrying. They are usually stimulated by chemical stimuli and thermal heat. They are relayed in lamina 1 to 5 of the spinal cord, dorsal horn. These are called paleospinothalamic tract. They carry diffuse type of sensations. They are non-specific, but they are associated with the behavioral and autonomic changes. In some of the experiments on the dog, it has been seen that A delta fiber stimulation produces the fall of pressure in the autonomic component in anesthetized dogs and increases the respiratory modality because the proprioceptive sensations are activated by low threshold. The C fiber stimulation also increases the respiration depending upon the situation. Sometimes it may, if it is arising from a particular region, it may inhibit, but they produce the hypertensive, it activates the cardio accelerator center or cardio excitatory center in the medulla that produces increased blood pressure and increased heart rate. This is an additional feature I am trying to give on the A delta fibers and C fiber stimulation. Here we have the spinal dorsal horn laminae. One consists of substantia gelatinosa cells. You can see that A delta fiber, the blue one, going there, relaying in 1, 2 and 5. That 5 is having a neuron, projecting neuron, that is WDR, wide dynamic range neuron. That would send it, that will now the axons of the WDR cross to the opposite side and ascend as a lateral spinothalamic tract. If you look at the C fiber, they are stimulated by high intensity. You can see the red ones, they will relay in 1 and 2. And in the 2, you have a neuron, interneuron. That neuron will communicate to the WDR, the wide dynamic range neuron. So that means the C fibers do not directly talk to the WDR, they talk indirectly. So that forms the basis of certain important aspects of the control of the pain or pain regulation. Now, the pain is carried by 3 different tracts. So that means lateral WDR gives the neurons, and that will reach the many of these fibers. They will ascend as a lateral spinothalamic tract, relayed into the ventro-posterolateral nucleus of the thalamus. They are placed laterally to the medial lemniscal bundle, and then after reaching the thalamus, they are projected into the parietal cortex area 312, that is sensory area. There are some fibers, they are giving information in the reticular system. These are spino-reticular system. These fibers end in the reticular activating system in the medulla and pons. And these reticular fibers, they ascend up, reach the thalamus, the intralaminar nucleus and reticular nucleus of the thalamus. From the intralaminar nucleus, the fibers reach throughout the span of the entire cortical mantle. That is for arousal response, and for also it will send information to other areas of the thalamus to activate the limbic component. Then there is a third pathway in which the fibers end in the midbrain, the spino-mesenchymal. That means they end up somewhere around the periaqueductal gray. And in this periaqueductal gray, they relay and they release certain molecules which reduce the pain. These are endogenous opiates, endorphins and enkephalins. This is the broad outline of that means 3 set of relays into the ascending paths. This is a classical, the major pathway for epicritic pain is lateral spinothalamic tract. Here on the left hand side, I have shown a classical textbooks which are describing from the dorsal root ganglia, relay into the dorsal horn neurons, especially you consider for WDR, wide dynamic range neuron, then cross to the opposite side, ascend up as a lateral spinothalamic tract. Then it will reach to the VPL and then make the primary, it will relay into the primary somatosensory area. That is what that thing. Other projection of the neurons I have already mentioned. They will reach the spino-reticular. That will, the projections go to the amygdala, cingulate gyrus and insular cortex through the parabrachial nuclei and amygdala. There are other neurons ending up, or collaterals ending up with the periaqueductal gray. They are concerned with the descending feedback to the pain pathways. Here is a homunculus. I will not emphasize on this thing. The picture is, you can just see that the hand, the lips and the face, the tongue, they receive large areas. So that means these are having a more sensitive, and if the other parts, the trunk and the back, they have a very little representation. So that means the area in the cortex, or area assigned in the cortex, is proportional to the functional significance of the part. That is the, you can just see that the greater representation there. That is, this is only for epicretic touch or a neo-spinothalamic tract or neo-spinothalamic sensation. Now, what I mentioned earlier, the three paths here in this picture, all three paths are summarized. One, nociceptor, relay in the dorsal horn, then ascend up, give collateral to the reticular, that is the medullary reticular system, that is a rostral, ventral, medulla. Then it will reach to the periaqueductal gray, that is a collateral. You can just see that these two are descending paths. Then parabrachial nucleus, that will go to amygdala. From the amygdala, the insular cortex and the cingulate cortex. The primary lateral spinothalamic tract will reach to the thalamus, VPL, and then that will be relayed into the somatosensory cortex. Now, the primary nociceptors and afferents relay in spinal cord, already mentioned. They will relay into the reticular system, and from the reticular system, the fibers intralaminar nucleus of thalamus, they will be relayed and they will be going to the entire cortical mantle. The fibers coming from parabrachial nucleus, already I mentioned, the amygdala, cingulate cortex and insular cortices. So they will be processing the pain for the behavior, for the affective, for the autonomic activity. What are the neurotransmitters in the pain pathway? I am just listing them. The glutamate is released at the dorsal horn. Enkephalins and endorphins, the inhibitory transmitter released from the substantia gelatinosa to the WDR, the wide dynamic range of neurons. They are inhibitory. Serotonin, they are coming from the descending projections from the bulbospinal tract, that is from the raphenucleus. Again, the norepinephrine, that will be descending from the bulbospinal tract. The serotonin is excitatory, norepinephrine is excitatory or inhibitory depending upon the type of receptors. If it is a beta receptors or alpha-1 receptors, it is excitatory, alpha-2 receptor is inhibitory. GABA, it will activate the GABA because through the interneuron, they will activate the GABA, that is inhibitory. I have not mentioned them. Histamine, it is an excitatory because glycine is an inhibitory. We have the peptides like substance P, the excitatory, because I have mentioned that there is a peptidergic and a non-peptidergic. Neurokinins, excitatory, adenosine, ATP, they are. Then tachykinins, the prostaglandins, again depending upon the type of prostaglandin, plus minus. The nitric oxide that may produce a excitatory or inhibitory, that will excite. Then calcitonin gene regulating peptide, that is excitatory. Cannabinoids, that is capsaicin and all those things, they are inhibitory. They are present not only in the spinal cord. I am listing them from the spinal cord. They are going into the reticular system. They are going into the periaqueductal gray, and they are going to the parabrachial nucleus, and then they are reaching. So all these are the type of transmitters the pain pathway involves. Now coming to, that is about the pathway of the somatic pain. How about a visceral pain? Usually visceral pain, viscera do not get the full representation as that of the somaesthetic sensation. Here I am showing on that the heart is the shoulder, that area is marked there. You can see the stomach in the epigastric area, liver and gallbladder, the right hypochondric and epigastric area, the pylorus, epigastric area, lower epigastric area, and little bit of umbilical. The appendix is coming to the umbilical area and the lumbar area. You can see the kidneys, the colon and ureter, the representations, how they represent the pain in the. Usually the kidneys, they produce a back pain and also not precise. Now these visceral pains, because they are carried by the sympathetic afferents, and they will reach the spinal cord, and from the spinal cord the pathways share a common pathway with the pain sensation, and they are not getting the due representation either in the spinal cord or higher up. What happens in the spinal cord? You just see that the referred pain or visceral pain we have on the left hand side on the top, the fibers reaching the WDR, wide dynamic range neuron, also receives from the dermatomal somatic structures, and it will activate the same projecting neuron. Hence, the pain is felt on a particular area in the dermatome. That is the convergence theory. Now it is fairly accepted. There was another theory, what is called facilitation theory, in which we have the neurons coming from the somaesthetic region and the neurons coming from the viscus or the viscera, and the one which is coming from the viscera also have a conversion or have a give a stimulus to the somatic dermatomal neuron, and that would produce. The second component, the facilitation component, is a little more complex. The first one, that convergence theory, is accepted in most of the textbooks, and they have now not talking about facilitation. What are the types of pain? There are three types of pain: nociceptive pain, neuropathic pain, and inflammatory pain. Let us consider them one by one. Nociceptive pain results from the activation of A delta and C fibers. I would note these nociceptors are present and are specialized free nerve endings located in various parts of the body: the skin, muscle, joint, bone, periosteum, or any internal organs. They detect potentially damaging chemical, mechanical, thermal stimuli, that is polymodal, which are harmful or potentially harmful. These are carried by the pathway lateral spinothalamic tract and spino-reticular tract or spino-mesenchymal tract. So to take that epicritic and protopathic modalities of the sensation, that is about nociceptive pain. So this is what we feel. This is a protective one, and this would help us to protect ourselves from injuries or the damages. Neuropathic pain is commonly seen in conditions where in the damage or the injury to the pain pathway, the neural injury in the entire pain pathway, maybe the nerve, the peripheral nerve, or the projecting nerve in the spinothalamic tract, lateral spinothalamic tract, or in the thalamus or above. And this pain is associated with a condition known as allodynia. Normally, touch sensation do not produce pain, but in conditions like a neural injury, a touch sensation will produce pain, and then that condition is called allodynia. To define, it is because of the repetitive non-painful stimulation of the receptors. So this non-painful stimulation of the receptors is triggered by the nerve itself. It is not by the external mode. So usually in allodynia, pain response is seen from a stimulus that is deemed as a non-painful stimulus. And it is because of the sensitization of the process. This condition can be, or neuropathic pain is a pathologic pain. And this does not serve any purpose excepting it produces an agonizing pain, which may be a continuous or comes as a intermittently as an episodes. The major causes of this type of pain could be due to the inflammation or metabolic diseases that have damaged the nerve, which may result from diabetes, uremia, trauma, the tumors, or other primary neurological diseases such as herpes zoster. After post-herpetic pain, post-herpetic of herpes zoster heals of this virus disease, and after some days a painful condition comes up, that is a neuropathic pain, and very difficult to treat. This is also called a casualgia in case of the peripheral nerves. Trigeminal neuralgia is also similar thing, and we have a thalamic syndrome. Thalamic syndrome, this is a cerebrovascular accident that is some stroke involving thalamic nuclei, and here it produces a pain in a particular area. It is a very agonizing pain. So these are some of the examples of the neuropathic pain. The inflammatory pain, we have nociceptive pain, neuropathic pain, and inflammatory pain. This inflammatory pain is because of the inflammation, may be acute or chronic. Acute pain is normally intense and occurs for a short period of time and is initiated as a response to harmful stimuli that are normally mediated by the fast-conducting myelinated A delta fibers. Chronic pain resulting from a chronic inflammation, it's a vague, dull aching, lasts beyond the expected period of healing and typically mediated by the unmyelinated C fibers. It's an agonizing pain, nagging pain. Inflammatory pain causes the increase in the afferent input to the dorsal horn neuron of the spinal cord and leads to development of central sensitization. During inflammation, number of chemicals are released from the tissue, and these chemicals activate nociceptors in the inflamed area. These chemicals are called, put them together as an inflammatory soup. They are the cell injury products like potassium, hydrogen ion, ATP, adenosines, or cell released products like serotonin, kinin, histamine, nerve growth factor, prostaglandin, glutamate, dicotyledons, nitric oxide, norepinephrine, and many others. The inflammatory pain or inflammatory chemicals produce what is called increase the sensitivity of the pain. This is called primary hyperalgesia. So that means normally there is some pain, but a little touch will produce much more pain. There is an increased sensitivity of pain, and this is because of the inflammatory mediators and also because of the increased temperature. Revising allodynia and hyperalgesia. Note that allodynia is a condition where pain is evoked by a stimuli which is not noxious, whereas hyperalgesia is because of the increased sensitivity of the receptors or the pathway of pain. The nervous pathway for pain sometimes become excessively excitable, and this gives rise to hyperalgesia. That means the neurons in 2, 3, 4 segments, they become hyperexcitable. Once they become hyperexcitable, they conduct the information about painful stimuli, while the receptor at number 1 is not excited. So this is a neuropathic pain, and this condition is known as secondary hyperalgesia. This secondary hyperalgesia results from the increased excitability of the neurons in the pathway as shown in 2, 3, 4. Primary hyperalgesia is because of the increased sensitivity of the pain receptors, the nociceptors, at number 1. Because of this thing, there may be hyperalgesia there is an increased sensitivity that may result from the stretch, the mechanosensors, chemicals, or thermal, or even normal other forms of touch also may produce pain if it is inflamed. So that is a primary hyperalgesia. To make the point clear, the primary hyperalgesia is happening at the receptor level. The secondary hyperalgesia is happening at the neural pathway of pain, that is 2, 3, 4. I have collected the information from the following resource materials: The Principles of Neuroscience by Kandel, Guyton's Textbook of Medical Physiology, the Genong's Review of Medical Physiology, article from Besabam et al. Appeared in Cell, and the article from M et al. Appeared in International Journal of Molecular Science. In the next lecture, we will continue with the processing of pain at various levels in the neuroaxis. Thank you.